Good morning. Just so thankful to be here, and I have um, some old acquaintances, some new friends, and just glad to be able to see each one and every one of you. What we do in our workaday world, at the Beyond Benefits side of the world, is all things health insurance, whether that be under 65, whether that be groups, or whether that be Medicare. And so we kind of have a different hat, different seasons. So right now we're in our heyday of open enrollment. Our Medicare world is going full force in our open enrollment from October 15th to December 7th. And then November 1st comes right around and kicks into gear, and it is for individuals or anyone under 65 that may not have group plans. So we've got that November 1st. That actually goes November 1st through December 15th for a January 1st start date. But it keeps going past that and goes till January 15th for a February 1st start date. So if someone missed it or needs to make a change, they still have a little wiggle room to change. It's just that it won't start at the first of the year. And then we have a lot of our groups have a January 1st renewal. So we're working on that too. So we just got different hats, different days, but we love what we do. It's just, if we feel like it's a joy and a blessing to be able to help folks. So every day is a new adventure. It is not a redundant, probably like you guys, is always a different world. There's a different scenario. There's a different need. And so it makes us, we have to stay on our toes. We have to make sure that the laws that are changing like the speed of light, and I'm sure with you guys, it's just one of those things where we never want to lag or like have that aha moment when it should have happened 3 months ago. We want to have to stay on top of it. So we start about July and start doing our certifications and everything for all the carriers and for the federal side. So we were ramped up and ready to roll. So when Medicare comes around or individual comes around, we've got certifications. And being a broker, we represent every carrier, every company, instead of one. So an agent does a one company and representative, and then a broker says, well, that may not fit that one person. So let's do make sure that we have every carrier so that we can fit the need of anybody and everybody at any given time. So anyway, but that takes months and months of certifications and credentialing and schooling to get there. So by the time we finish, it's October and we've got a later roll, time frame there. This is one of those times where I want to open it for Christians in a few, but I want to kind of give you a feel for pre-65 and after 65 Medicare. I assume you're not on Medicare. So this way I can tell you a few changes that are happening inside of the Medicare side because they're significant. And with the Inflation Reduction Act that passed, it's actually still in progress. It's still a in motion thing. But I want to give the folks that may have do not have Medicare, but maybe you help someone or know someone or have family members or mother-in-law or something that is on Medicare, kind of the updates on some of the changes as well as those who are on it. But in 2025, you may have heard the infamous donut hole. That word, that donut hole. Okay, whoever designed that must have hated their mother because it is the worst. It has been the worst of kicking the pants for folks that have a lot of high-end medications, because they will have, it's like a maximum amount of pocket of $8,000. But until then, you're having your coverage until you meet basically $5,000, and then after that, when you hit that coverage gap, or they refer to as the donut hole, it's a gap in coverage where you're suddenly paying 25% of the retail. So if you're on Farxiga and at $1,700, you become liable for 25% of that. Well, fine and dandy unless you are on a very fixed income and you're 87 years old and you have, sometimes it's food or my prescriptions. Well, I can't do without my insulin, or I can't do without, so I guess I'll, and it becomes a real hardship. So we cry tears with folks sometimes because of what has happened throughout the years by the time they hit that coverage gap. And then suddenly they are in a world hurt. That's gone away. So in 2025, again, the Inflation Reduction Act says we have now a $2,000 maximum out of pocket. And I know you've probably seen some news about it or a news blip here and there about this new $2,000. But what's wonderful about this is it's not a $2,000 out of everybody's pocket. It's a $2,000 combined out of pocket with the manufacturer paying their sliver of 10%, the carrier. So like if it's Blue Cross, if it's United Healthcare, any of those, they're paying 65%, and the member's paying 25%. So if all sum total, now I've had folks that have some high-end Farxiga, Eliquis or something, they might get to May, and that combined combination of everybody paying their portion, suddenly they get to May and they're done. They've paid it up. They may have only paid $400 for the year, and then the rest of the year is zero for May, June, July, all the way through, and they have no more cost. So that is such a blessing. There's always a little pitfall, though, because in doing that, the carriers are going, wait a minute, we're picking up all that extra, so we don't know what the long-term ramifications will be, because some of the carriers are going to probably say, we've got to absorb that, so we're going to have to take away this, add this, increase our premiums. So we don't know what the future holds, but right now it's very sweet. So in 2025, folks that have been harmed are suddenly doing the dance because they are having the blessing of having just an nth of what they've had before. And a lot of folks that we have say, well, I was prescribed this, but I can't take that anymore because it's too expensive. I can't take it. They say it's best for me, but I can't take that because I can't. Now putting it on the plate and sometimes even adding more prescriptions makes it where they hit that max out of pocket quicker, and they actually have less out of the pocket than what they didn't take it. Does that make sense? Because that retail is adding to it, and they're actually getting there quicker. So we always laugh and say it's Common Core math. It's like, who came up with that? But it works. So anyway, that's one of the biggest changes I wanted to share with you for next year for any folks that have had that problem of high medications or know of someone, and it's like, no, we've hit the donut hole. Okay, far, far away. We don't have to worry about that anymore. One of the consequences of that, though, with this new $2,000 instead of $8,000, now it's $2,000, is the work side. So now there could be a problem. If folks, let's say if I worked at Eastman and I'm 67 and I have a spouse who needs coverage on my group plan. So now the law says unless you have coverage as good as Medicare's and you're not taking Medicare at the time that you're eligible for it at 65, because there's a good reason, maybe a spouse needs it and you're not taking it, then you will be penalized 1% for every month that you don't take Medicare and stay on your group plan if it's not as good as Medicare's $2,000 cap. So suddenly they're going to have a lot of folks who are going to be left in a lurch because they can't stay on their group plan unless they can, but they'll be penalized. And when you get penalized 1%, so let's say it's 2 years, and they stay on it from 65, 66, 67, because my wife or my husband is 63, and they are they need coverage because if I leave, their coverage goes down the tubes, and they will have that penalty that sticks with them for life, and that 1% that adds up per month is always until they could be 200 years old, and they're still paying that penalty from back. So that's where the downside is. In the big picture, everybody has to have coverage as good as Medicare's, or they'll be penalized. So they're giving it was supposed to start in January 2025, but they're giving a soft pass this year. because they didn't really get that out. They did with the election and all the things that happened, they didn't say it. So 26, line in the sand. 25, they're going to start warning, and saying, if you don't, you better. So again, if you know any family or friends or anyone that is in that situation, know that this is the last 12 months where they can start figuring it out, because they better jump. Now, their family member can go on the individual plan. It's just they better go on the individual plan, because it will be a factor. It will be a penalty. And then, like I said, and that can make even a zero premium Medicare plan, suddenly they might be paying $30 because they have that penalty, and everybody else pays zero. So anyway, I just wanted to tell you the goods and the bads of this $2,000 cap. Another thing, and I'm kind of focused on Medicare, and then I'm going to swap back. They're actually saying now in the Medicare world that Medicare, the carriers or the companies like Blue Cross, whatever, they have to send out anybody who's on a Medicare Advantage has to send out a. And remember, there's two different ways to go in Medicare: Medicare Advantage and Medicare Supplements. And one is an old school, and one's more newfangled. But the newfangled, they're saying, if you have a benefit for dental, vision, gym membership, over the counter, Medicare's the new law says you have to tell these folks what they haven't used and their balance in the middle of the year. So by July 1st, they have to know what they haven't used, so they can use. So if it's over the counter and they had it in their plan, and they could go to the CVS and get something over the counter, but they haven't, it's by law now that they have to tell them, hey, there's something on the table here that you haven't used. My worry is, again, with all this extra paperwork, expense, calculations, all these things that they get out there, again, in 26, 27, will it catch up? Will they suddenly say, the carriers say, we've lost our backside, we're going to have to up this, take away this, and so we could see, again, some adjustments in the time to come. So it also sometimes benefits on the front side can be, again, kicking the pants on the backside, but we yet to be seen. But that's something new in the Medicare world. They've also expanded the telehealth, and that's kind of a little note that I put on there. They've quadrupled their wellness or your preventive. So, and their point was to make it where early detection is a better route to go than on the backside where it's already a little late. So they have whatever health issues are happening that could be caught ahead of time, Medicare's paying more now to get you set. That also applies to to under 65 non-Medicare folks too. That they are trying to increase their wellness and what they cover at 100%. So even a group plan is going to see more wellness built inside of it now. So, and it only makes sense that they would have that as a thing. Trying to think of some of the things that would be, again, more new for your Medicare. Back to the individual side, for those who aren't quite yet to the Medicare world, they have expanded their plans on the individual non-group. That would be richer, bigger, better. Blue Cross came out with about a 12% decrease for individual side, and it still has the tax credit availability. So, and they expanded that to a broader scope. So your more income still produces a tax credit. So the tax credit with the marketplace is where the individual side says, okay, this plan for you is based on your age is $597, but with your income, we're going to reduce that to, maybe we'll give you a $400 tax credit. So maybe now you're only paying $140 instead of the $540 or so. So the tax credit is a amazing thing where it has been provision. Obamacare is where it came out, but that's just another word for the marketplace or capability to get in that tax credit through the marketplace. And the marketplace is not a insurance on its own. It's still Blue Cross or Cigna or one of the carriers, but it's a vehicle to get that tax credit. so that you're not paying this much, you're paying this much based on your income. So so that has expanded. We had a couple the other day. They made around $210,000 between the two of them. They still got a $400 tax credit. So it's not like, oh, I make too much, I won't be able to apply. It's still a thing. So that margin is larger, so that folks can still have that tax credit based on your age and your income. But in the tax credit side, as I mentioned, whatever they feel like their future income will be. I'm going to retire. My world's behind me of salary, but now I have a fixed income. I'm going to be withdrawing this. I'm going to be withdrawing that. I want to live. So in that world, they can still probably get a fairly nice tax credit, and that tax credit comes right off the top. So if they're, again, right off the premium. So it's not a tax credit where at the end of the year, and when you're doing your taxes, you can see that, even though that factors into it, but it's actually day one off your premium deduction from their premium. So if a couple might have had a $1,200 or even offered a $1,200 through their retirement side under 65, and it's $1,200 or more, $1,800, I've seen it all, they might be able to get that same plan for $600, $700, $800 because of the tax credit, because of what their new world of going forward. So you don't have to look back, you can look forward in your prediction or your estimate of your income for the following year. So it's, and then they can get a pretty nice plan, again, through Cigna, Blue Cross, one of those others. I was going to say something too about the, yes, and here, when I keep flip-flopping, but in the Medicare world too, back to that, I meant to say this before, in the Part B, everybody that goes on to Medicare has to pay for Part B. A, we've paid into the system, it's free. That's what we're doing everyday life. When you say part of that is going to Social Security and part is going to Medicare out of any workaday world check, that's going to pay Part A. So Part A has been paid up. That's why it's not technically free. You've already paid it. But Part B is going to increase to $185 in our following year. But if your income is in any bracket, this just got released a week ago Friday, and you've probably seen that, where it's going to be in an increased income Part B, rise. We always inadvertently say, oh, the penalty. No, and they want to smack us. It's just the IRMA. You worked your backside off, and it's the IRMA increase or the IRMA. So they add that and tack that onto that 185. So depending on where you land in your how you file, will be that increase of your. I meant to give you one of those too.
Yep. That was in my thoughts too.
Yeah, it's just because you're going to see it's bad. It's really went up. So So like I said, that's where I'm worried about the ramifications of some of these wonderful things catching us on the back for some things that may not be so wonderful, or our correction starting now. But I think in 26, we're going to have a lot of carriers, even in the Medicare world too, dropped out. So a lot of prescription drug plans, as we've talked about, we had almost 30 plans in our area that were prescription drug plans, standalone prescription drug plans. We have 14 now because a lot of them went, I'm out. Mutual of Omaha completely across the nation pulled out. They're no longer a prescription drug plan company, that portion, because they knew that they were going to be absorbing 65% of everybody's plan. So they were like, how can we? Now, it's being subsidized by Medicare, but still that's a chunk of change out of their pocket that wasn't before. So we're seeing that happen too. They're slimming down. So that's what I also worry about in 26, 27, 20. If there's now 14 just because they announced it, what will happen when the reality hits? Oof. And then some of the companies that might have 3 or 4 plans are now one plan. They've consolidated to try to bring in that whatever. So again, Medicare and on the individual side, I'm seeing some of those shifts. So, but anyway, I forgot to mention that. So, any more questions?
Maybe somebody asked, are does a tax credit have any certain relationship to that cost?
No, just on the under 65s, that there's a tax credit. This is what it is what it is. Just right out of. If someone is drawing Social Security at the time that they take Medicare, this is automatically withdrawn from your Social Security. If you're not drawing Social Security, but most of the time you would be after retirement, but if you're not, then you just cut a check for this times 3. They only do quarterly. So anyway, but one thing they do have, if someone retires, and this is again, if you have friends or someone retires, and that automatically they'll do a 2-year look back. I think we talked about that too. They'll do a 2-year look back and say, based on your income or your situation, or if you sold houses or you did something back then, got an estate settlement, whatever, that's what they go on that penalty, that IRMA, what your income is. But if you say, hold the phone, that was a situational thing. I had an estate settlement. I had rental homes that I sold, whatever. It's not the same now. You can appeal that. And so, you could just say, no, going forward, this is me. And they will reverse that. And I've seen it happen. And if nothing else, it'll maybe go down a notch or two based on the fact. A lot of folks don't realize that. And they're like, it is what it is. And eventually it'll catch up, but they're not real prompt to say, today I'm going to, Medicare proper will not acknowledge it for a while. But if you bring it to their attention, they have a good chance of reversing that. So A and B are the core, is what you have to have with Medicare to get any type of plan. A is all things hospital. B is all things outside the hospital. Doctors and lab work and MRIs and CT scans and wheelchairs and walkers. And B, inside the hospital, part A. So you cannot have C unless you have A and B. You cannot have D unless you're actually entitled to B. But your A and B are paying that 80%, as I mentioned. C is where it comes up, and it's a Medicare Advantage. So Medicare Advantage is considered C, and that's where it takes up the slack and picks up that 20%. You might have a copay here and there, but you're paying they're paying the other 20 for you. But it also includes the D for prescriptions, or remember, D for drugs. Sorry, you've got you've got the bases loaded with the Medicare Advantage, and the fact that you've got A, B, C for the covering the medical, and then the D. The other side is Medicare A and B as a core, having your Part D prescriptions, and having a supplement, where a supplement is a standalone. Different carriers, different companies will have it, and it picks up basically 100% of everything inside and out of the hospital. There's a little deductible, but as a whole, it's picking up 100%. And there is no networks. You can go anywhere in the nation. If I had to go MD Anderson, Mayo Clinic, Cleveland Clinic, get in the car and go, because there's no Mother May I. There's no networks to work with. There's no Blue Cross or Cigna, or it's just a definite straight you and Medicare. So, the only downside to that is there's no dental, vision, fluffy stuff in it. But boy's a Cadillac though. It's just a Cadillac without pinstripes. And then the Part C, you're adding some dental and some vision and some over the counter and some nice fluffy things that add to it. But it comes at a cost. You have an out-of-pocket maximum. You're paying copays until you get to a certain amount. So it's kind of a pay me now, pay me later. But the supplements, you're paying now, you're done. So it basically is, again, it's just tops. But a lot of folks go with the Advantage just because it does have, boy, I could stand that dental. I really need that. And boy, I like the fact that prescriptions are inside of that. And I got one card. And pharmacy and dentists and doctors, and I've got the one card. So there are some pros and cons for each, and that's why it's personal. And they'll allow everybody to kind of have their own choices. Even a husband and wife can sometimes have two different. One will pick one will pick the other based on their own needs. So it's kind of neat to have that. So.
I can't thank Alicia enough for agreeing kind of on short notice to do this. And we send so many people, as soon as the word healthcare comes out of someone's mouth, we're like, well, this is my kind of outside looking in thoughts of it, but you need to go talk to Beyond Benefits, and they really do. As we've kind of seen in that talk, it's so personal, and there's so many different options. Until you sit down with your situation, and that's kind of the problem when someone comes to us and asks about it. We have that general knowledge, but we can't pull up what plans might be good. You might be on a particular medicine. I know, for example, my mother-in-law has one medicine because of that she's on that's just not an easily coverable drug. And so there was a patient assistance program at one point that we kind of got help finding. And now, hopefully, maybe with the changeover, maybe we go back to it because those patient assistance programs, stop after a certain period of time. So there's just so many different things. It really helps having experts in that subject do that. There were a couple things that I wanted to mention kind of in the healthcare world in retirement that we hit and talk about. And I'm just going to briefly hit them, and if anybody has questions, but these are things that kind of come up for us a significant amount of time. One of them, Alicia already talked about, which was the IRMA and the Medicare. And what a lot of people don't realize is these one-time events that can dramatically increase your Medicare costs. And they're like, why? Out of nowhere. And, they file their tax return. That's where they get these numbers from, is the tax return you file. And so all of a sudden, to give you an example, if you're between, I guess, 133,000 and 166,000 as an individual, or 266 and 334 for a couple, your per cost Medicare Part B is $185 next year. If you have one kind of event that takes you higher in that 166 to 200 or 334 to 400, that jumps to $295 per month per person, on your plan. So when you look at that amount of a jump, you're talking over $100 per month per person. So all of a sudden, a $2,400 in a married filing jointly situation just decrease, and it comes out of your Social Security. So in most cases, and there's a lot of reasons why that might happen. And so it might be, well, I decided to take money out of my IRA because I wanted to buy a car or help my child out, or whatever reason you might pull money out legitimately, and you're above the IRS penalty, so you're not 59.5, so we're not paying 10%. But then all of a sudden you're adding in, oh, well, it cost me $2,400 extra dollars that didn't cost me to the government on my tax return, but it's coming out my monthly pay. We see it, Alicia mentioned estates. It's not uncommon for someone to inherit an IRA, be like, well, I'm going to pull the money out. I'll pay the taxes because I didn't have this money anyway. You pull the money out and you're like, it's just $100,000. Although I realize that's a weird phrase to say, being just 100, but I'm going to use that 100. I'll pay the taxes on it and do X, Y, Z. That's what mom or dad would have wanted me to do. And all of a sudden you're getting hit on your medical. So that's kind of where we come into that equation on the medical, is what do those decisions, do to affect? And then it's working with someone like Alicia to get those squared. The other place, there's two other places that we really talk, and Mindy's here, so she would be better able to talk about long-term care. But that in retirement planning and healthcare, long-term care is top of mind. And the number, it depends on who did the study and who did the research, but I've got a few things here. 1 in 5 adults will have a care need. Duration for women is about 3.5 years, men 2.5 years. Across the board, if you go, young to old on long-term care, I think the average long-term care is sitting around 18, 19 months. And so when we talk about that care, it's significant, and it's gone up dramatically. It used to be, not that this is cheap, but you used to be able to get someone to come into your home, sit with a parent, do whatever, $10 an hour maybe. We're well in excess of 20 now. So the average home-based care is right around $90,000 annually now. there's kind of four different things they talk about. And one of the things that started, and this is a new phrase for me, it's adult daycare. And actually, I've not visited, so I don't know if it's exactly what they do, but right up here over where it used to be the Plum Tree restaurant, there's an adult daycare. But that's basically where you can, instead of having in-home, you drop your parent off as an adult daycare. That's running around $16,000 a year. If you go next step up, assisted living, still able to function somewhat on your own, $65,000 a year. And if you're in full skilled nurse care, $115,000 a year. And so a lot of times we look at that and say, well, how am I going to cover that cost? And if you look at the traditional, well, I can pull 4% from my retirement account and have the retirement account never go down. You're talking about 4%, to get these numbers, you just divide those numbers by 0.04 and get there. So if you didn't want it to affect your, monthly cash flow, you need an account of 2.2 million for home care to pull that 90,000 out.
And that's for today.
For today. And so looking forward, it's just going to keep going up. Or 2.9 for skilled nurse care. And that's if you only want to pull 4 and leave your retirement. So what we're seeing is these retirement accounts, because we're having to pull so much more out, dwindling and dwindling. So it makes that period of time of how long will my money last shorter and shorter. So that's where, long-term care policies, the old answer used to be, they're really expensive, get them when you're young. That equation might be flipping. So it is worth talking to people and really examining your situation to see whether or not long-term care makes sense. Coupled with that, we look at when should I take Social Security to kind of offset those costs. And you can start taking Social Security at 62. And if you looked at today's number, the average full retirement Social Security was right around $1,800. It was $1,783 per month across the nation. Now, clearly, you've got people making way more than that and way less. It's based upon your X number of months best earnings over the last period of time. But the average was at $1,783. If you took that $1,783 and took it at 62 years old, you drop to $1,254. The question is, well, why would I give up $500 a month, for that? Well, $1,284, if I'm trying to offset a $5,000 nursing home bill, that can be a big difference. And so what we do is we run numbers that look at, there's a break-even point. So if you start taking that $1,254 at 62, not counting cost of living adjustments and everything else, compared to waiting till you're 70, you will have made $120,000 from Social Security distributions. At 70, if you had waited, because after 67, you start going up 8% per year. And it's by month, but it's 8% per year. But at 70, that benefit that was $1,784 would be $2,209. So there's a break-even point there of 54 months before you start getting $1 in addition type thing to what you would have made, because you've got to make up $120,000 whole. That may make sense. So if you have assets outside that you can help cover these costs, great. It may not make sense. And so that traditional answer that kind of got beaten into a lot of people's skulls of wait on Social Security, wait on Social Security, wait on Social Security, you can't get an 8% return anywhere, may not be the truth for your particular situation. And the way Social Security kind of looks at it is the average life expectancy, and this is why that 5-year number is kind of interesting, including all mortality, so infant all the way to the end. The average life expectancy in the United States is 77 years. For men, it's 74, and for women, it's 80. Well, if I'm 70 and I need to add 4.5 years and I'm a man, I never break even, right? So all that break even extra 8% earnings was in later life. Now that those numbers do shift for people who do make it to 65. After 65, the life expectancy for men is 82, and for women, it's 84 and a half. And those numbers have come down. COVID did a big shift in life expectancy numbers, which changed all the tables. But it's definitely one of those things that you're playing into. When do I take? When do I not take? Do I need to get long-term care? A lot of times we'll have people who come in here like, well, my dad dropped of a stroke at 55, his dad at 60, I'm not going to make it that long. I'm like, well, maybe we should start talking about taking, it's not the mathematical right answer, but maybe we should be taking Social Security at 62 and get that benefit. So those are all things that we look at in helping retirees and pre-retirees or people who have parents who are going through this, right now. Those are all kind of part and parcel of this conversation. So it's really important. The earlier you can get started, like Alicia said, 3 months could be a big difference on whether or not you qualified for something this year or next year. And those are all kind of in this world of planning for costs, because retirement accounts have grown. The market's doing really well and they've grown, but we've also had this shift to where it is very dependent upon the individual to plan for their retirement. And a big part of that is the healthcare costs, which didn't used to be such a big part. Because we used to have defined benefit plans. You worked at Eastman or you worked wherever for 30 years. Okay, well, for the rest of your life, you're going to get this pension. Well, now it's really based upon, did my investments do well? Did I stay invested during the time period? So even starting at a younger age, that's why it's now so important to get started investing, because it is really all on you in retirement. And, they always say, don't plan on Social Security because, it's going to run out of money and all this and the other. Chances are they will do something to fix that, but we do have governmental issues there as well that Social Security may not be there for, in the same capacity at least, for the next generation. So kind of that old thought process of I'll just get to retirement and I'll live on Social Security, maybe is not the best place to be. Because if you think about it, $1,700 a month for an individual, is that enough to live on? For certain people, yeah, I've paid off my house, I have no debt, I'm not traveling, I'm healthy, I'm staying at home, cooking every meal, I don't have a car payment. $1,700, on Social Security can cover a lot of that. But we're seeing more and more people with the cost of education, with the cost of healthcare and the cost of everything else, housing, not hitting retirement out of debt. And so those are all things that we kind of try to plan, and the earlier we can do it, the better.